Hi, my name is Dawn Marie Stull. I'm with Takeda Oncology. I work in their Global Medical Affairs Department and focus on treatments for multiple myeloma. I'm really excited to be here today to talk to you a little bit about a study that we're presenting at ASH this year that looks at outcomes for multiple myeloma patients treated with ixaxomib, Revlimid, dexamethasone, or often referred to as Ninlaro, Revlimid, dexamethasone. The background for why we embarked on a study like this and an analysis like this is that there have been some analyses done that show that when we look at the broader multiple myeloma population and we look at eligibility criteria for randomized controlled trials, that up to 44% of newly diagnosed patients and up to 72% of relapse refractory patients would not be eligible for participation in these pivotal phase 3 trials that are done to lead to the approval of new medications. So based on that fact, what we're left with is a situation where we've proven the efficacy of a drug and we can get that drug approved, but it leaves us with a bit of a gap in terms of understanding what the true outcomes and what the safety profile will be when it's used in a much broader population of patients. So how do we fill that gap? Well, the way we do that is something called real-world evidence. So the abstract and poster that we're presenting, called the INSURE analysis of the use of ixaxomib, lenalidomide, and dexamethasone in real-world patients in the relapse refractory setting, helps us to fill that gap. And what real-world evidence is a collection of information about treatment patterns and outcomes when these regimens are used in this broader population of patients. And what we often see is there is a difference in the outcomes and the tolerability when you look at the results from a randomized controlled trial and then the results in the real-world setting. So another thing that I'd just like to note that's really important before we go further, real-world evidence is complementary to what we learn in our randomized controlled trials. The randomized controlled trials will never be replaced. They are the way we get new drugs to patients, to help patients' quality of life and improve their survival. But as I just mentioned, there is this gap in this understanding, so real-world evidence, when used with RCT data, kind of provides a full complement, if you will, or totality to better understand how patients will do on a regimen. So let me talk a little bit more specifically about the data that we're showing here at ASH. So this INSURE protocol pooled data for IRD-treated patients from 3 different real-world studies that Takeda conducted. We have our INSIGHT-MM, which is our large global multiple myeloma registry. We have another study that's called the UVIA-IXA study, which was done in Europe across many countries. And then we have another study called REMIX, which was done specifically in France. And when we pulled these data, we found that the effectiveness that could be achieved with IRD in this very broad population of patients was comparable to what we showed in terms of efficacy in our pivotal Tourmaline MM1 study. So for those of you who are more familiar with the data, you may recall that in our MM1 study in relapse refractory patients, we had a median progression-free survival of 20.6 months and an overall response rate of 78%. Well, in this pooled analysis of over 560 patients, we have a progression-free survival, a median progression-free survival of 19.9 months. So it's almost exactly the same. And our overall response rate is 65%. So we are really happy to see that the outcomes that we're seeing when this triplet is used in this broader population of patients is quite comparable to that pivotal study. The other thing that's really important about this analysis, because we were able to increase the number of patients to over 560, we're able to now look at subpopulations that are of particular interest who kind of fit into that gap that I mentioned earlier on, where we just don't have data on these specific types of patients because they're not eligible for inclusion into clinical trials. So we're reporting for the first time a high-level look at how patients do who are considered frail versus non-frail. And we determined their frailty status using something called a simplified frailty scale that was published a few years back. And it's considered a validated tool to assess the frailty status or the fitness of myeloma patients. And what we found in this analysis was that the progression-free survival for the frail patients was about half of that in the non-frail population. So the PFS was about 12 months in the frail patients versus over 22 or going on 24 for the non-frail patient populations. And while at first that might sound a bit discouraging, in reality, when we think of an elderly or frail patient, a median progression-free survival of 12 months is quite good. And maybe even more importantly than that result in and of itself is the fact that this really gives us more insight into what to expect in terms of outcomes that can be achieved in this frail population, and helps us better understand what is really achievable and what can be expected, so that healthcare providers can better inform their patients. Just a few final comments. I would like to note that there were no new safety signals seen. The tolerability was quite good, just as we had in our pivotal MM1 study. When we look at reasons for discontinuation, if we focus on adverse events, the two main adverse events leading to discontinuation of the triplet were thrombocytopenia and diarrhea. And just in totality, again, we're just really excited about showing that the effectiveness appears to be comparable to our efficacy, and that with this larger cohort of patients, we're able to drill down and learn more about these subpopulations that are typically not represented in randomized controlled trials. So we're going to be digging deeper into this analysis of frail versus non-frail, and we're going to be looking at some other subpopulations and hope to present data at future congresses to help inform the management and care of multiple myeloma patients. I'd also like to thank the investigators and the patients who participated in these studies. They are not easy to do. The data collection is complicated, and without all of your efforts and willingness to participate, we wouldn't have this data to learn from. So thank you very much.